Okay. Well, good afternoon, everyone. I hope everyone's Monday is off to a great start. I wanted to, first of all, thank you all for spending time with us today and being here for our September webinar, which is on graduate mental health and suicide prevention. I look forward to our wonderful dialogue that we're going to have today with our two panelists. Before we get started, I just wanted to kind of share more about the Wellness Committee. So my name is Alexis Faison, and I serve as the Director of Wellness for the Graduate and Professional Student Association. So in this role, I work with the committee, a dynamic and a wonderful committee that meets regularly to discuss programming for graduate students as it pertains to mental health concerns and well-being. I believe as a committee, we have a vested interest in ensuring graduate students' mental health is made a priority. I think we all can acknowledge that when our mental health is made a priority, then we are able to succeed as graduate students and as students overall. So our committee, ultimately, we plan different events this month and future months coming. You'll see we have like a monthly webinar topic. We also have upcoming mindfulness and yoga practice in order to work on our mindfulness, and also, we'll collaborate with sustainability so that we could be more mindful in our efforts to protect not only our well-being, but also the earth and our spaces around us. So, we have, like I say, a lot upcoming this academic year, but today is, like I said, all about suicide prevention and graduate student health. So before we continue today, I definitely want to make sure that we introduce our two panelists here. We have Aaron Cromar, and then we have Emily. If you all could just briefly introduce yourselves.
I'll let Emily go first.
Okay.
That sounds great. Hi, everyone. So my name is Emily Hinsberger. I am a graduate student here at ASU. I am in the Masters of Counseling program. I am also the management intern at the Counseling Center. I've worked with ASU students, staff, and faculty over about 4 years now. I was also here in my undergraduate working on mental health initiatives for students and faculty, and really just being a beacon of resources in the community. So I'm really happy to be here to talk with you all.
Hi, my name is Aaron Cromar. I'm a fifth-year PhD candidate in the College of Nursing and Health Innovation, the Edson College of Nursing at ASU. My research primarily focuses on how technology impacts suicide-related behaviors in young adults and emerging adolescents. So this topic is very, very near and dear to my heart. Another piece of my background is that I've been trained as a forensic autopsy specialist, which sounds a lot sexier than it actually is. There's going to be no TV shows. There's no CSI. There's no TV shows going to be made about it. But I do have training in that as well. And I'm very, very grateful that we have an opportunity to kind of close out Suicide Prevention Month by having a webinar to discuss it.
Great. Thank you both for taking the time to introduce yourselves. I think let's kind of jump right in to talk about, why is this topic important? Why do you think it's important to have a conversation, just generally speaking, as it pertains to suicide prevention?
Emily, you want to go first, or you want me to go first?
I can go first. Sorry,
Okay.
I was just refreshing my questions. So just mental health and physical health are so interconnected. And I think just stigma wise, we often separate these two aspects of our lives. And so when we think about mental health and the community around us and those that we care about deeply, we often separate them. And when we do that, I feel that we perpetuate this stigma that mental health is different than physical health. So having these conversations to talk about, what are the resources to get help for our health? What are these conversations looking like when we help someone with their health? Being able to break that down and really communicate that us as a community, we are the beacons of those resources. We are the beacons of health. We are the beacons of, connectiveness. Humans are just naturally social creatures. And oftentimes we forget that our health is a biology, sociology and psychology, and social, again, the sociology coming in. So we are connected on so many different ways with our health. So being able to communicate all of these different resources and ways that someone might be struggling or needing support is super important to have. We have to break down those ideas and bring in that biosocial psycho model of connectedness. So that's why this is so important to talk about. It's not only just that it's a sensitive topic, it's one that we find too sensitive, and really bringing that to the forefront that we can talk about these different situations, but also in the light of hope and connectiveness. Just the bottom line is that you are not alone, and there are so many people that want to help. Oftentimes education around how we help is super important. Aaron, would you like to build on that?
Yeah, well, and I think that's super interesting, because there was a recent study done in 2021 that was done by the National Academy of Science, Engineering, and Medicine in the United States. And what they've done is they've kind of tracked increases in various rates of behaviors, and over the period of 2013 to 2018. They've seen marked increases in major depression, anxiety, substance use, particularly upticks in cannabis use, marijuana use. And then they've also seen upticks in both suicidal ideation and then planning and behaviors as well. And all of that's not great. But that was pre-pandemic. And then I think where the pandemic becomes, kind of the most prevalent, and what we're seeing post-pandemic is from 2019 to 2020, just that 1 year between the pandemic, at the beginning of the pandemic, there was a twofold increase in depression among graduate and professional students. And then that was also the highest they've ever seen attempted suicides compared to any other year as well. And so I think that that's a very prescient backdrop as to kind of why we're talking about this issue, why it's so important to consider this issue, particularly given the way that the last couple of years have gone with COVID.
Yeah, thank you both for that response. And Emily, going back to something you mentioned in terms of it being obviously a sensitive topic, I'm curious your thoughts on, there seems to be like this public perception that talking about suicide will make someone consider it. What are your thoughts on that? Is that accurate, or is that kind of like an inaccurate perception?
I can tell you for a fact that that is a myth. So when we ask someone, are you contemplating suicide? Maybe even passively, do you feel that you are not content with your life and no longer want to live it? When you ask those questions, what you're asking right there is, are you contemplating? Are you thinking about it? Do you have this connection with this idealization? And so oftentimes when we do ask it, that person has been feeling it. Not saying that everyone that you ask will be suicidal or have experienced that feeling, but when you ask it, it does not enact that person to act on those ideas. Oftentimes, this is the opportunity that they have to ask for help. It's really empowering, in fact, to ask that question and have that person be able to give an honest answer, because oftentimes many people won't ask, and that can be a bigger consequence of it.
Yeah, I completely agree, and I support Emily in what she just said. The concept that you would give somebody the idea to become suicidal is absolutely a myth. It's a terrible myth that the sooner we can dispel it and be done with it, the better. But it's absolutely a myth. Now, there are some concerns about, contagion, a social contagion aspect of it, which I think we might talk about later. There are some strict media reporting guidelines in terms of not reporting certain details about cases, because there have been like small upticks noted, particularly around celebrity suicides. So in past celebrity suicides, there will be like a sharp, just a little uptick after those suicides of people that it's kind of like copycat syndrome, right? Or copycat crimes. But that's why the media reporting guidelines are there. But the general idea that you could talk like you could give somebody the idea and that it's an Inception like type of a thing is not even close. And instead, I think Emily's right in the sense that by not asking, one of the consequences that you run is by not asking, you make that person feel more socially isolated, more lonely, more as if people don't care about them, rather than asking the question. I think asking the question shows and demonstrates care rather than the alternative. And the alternative are distinct risk factors for increased suicidal thoughts and behaviors.
Yeah.
And then I would just want to build on that real quickly. When I think of suicide, I think when we contemplate that, we think of this very violent act. And how I view it is a disease of loneliness. It is not necessarily this disease of violence. It really is just this idea of this final stage of a disease. And that's how I see it. And if we can combat it at that loneliness and really recognize it for what it is, asking those questions aren't as scary as the final product, that final stage of suicide.
Mhm. Thank you both for your insight into that question and really acknowledging that that is a myth, that we should be having these conversations. And Aaron, you mentioned something regarding social contagion. Can you share more about that? I think you've kind of alluded to it, but maybe you can provide more insight.
Yeah, so there was a really great book by what was his name? I think his last name is Kravitz, and he wrote a book recently. It's Lee Daniel Kravitz is the name of the author, and he wrote a book recently called Strange Contagion. And essentially what it does is it looks at the idea of social contagion and essentially like emotional contagion or emotional transference of the idea of suicide. And what he did is he looked at a couple of high schools in the Palo Alto, Silicon Valley area of California that were plagued by multiple suicides for a couple of years in the last few years, to see if there was this contagion aspect. Like, could you transfer an idea between people, and was one suicide likely to cause another? Like, was there this chain reaction? Was there this chain of events that you could connect? And the idea is not always supported by the evidence, mainly because it's very hard to connect suicide in that way. And this is where the psychological autopsy part of my work comes in. Is it's sometimes very hard to see why people commit suicide or why people engage in self-harm behaviors. It's not usually because other people, like, they see other people do it. It's not necessarily because they were exposed to like harmful images, harmful news stories. Like I said, there's a small connection with celebrity suicides, but again, I don't think that's really robust in the data. I think that more it goes back to Emily's point of it's a disease of loneliness, really more than anything, or a lack of social connectedness. And some of those things that could more cause more of the contagious elements are really more of like the social, emotional, like psychological triggers that Emily was also talking about, in the sense of like, what are the risk factors, what are the triggering events that prompt behaviors of loneliness, of social isolation, of lack of connectedness or disconnection from previous social and family relationships, that type of thing. So that's my experience with it so far.
Okay, thank you for that. And kind of continuing the conversation, if you know someone that may be feeling suicidal or maybe having these passive thoughts, what are some good ways to kind of ask if they are indeed feeling suicidal?
So there are about two ways that I usually go about asking if someone is suicidal. So I often refer back to Brene Brown. So she's one of my favorite authors. She is a social worker and she talks about all sorts of emotions and all of the connectiveness between them. And so she came up with this concept of clear is kind, and that is just being open and direct about boundaries. But I think it ties into this being direct is very kind. And I think oftentimes in our culture, American culture, we like to tiptoe around those sensitive topics. Often when we ask someone, how are you? You just reply, good. But if you ask someone, no, how are you really? You often get this deeper, more fuller connection with what is going on. So when I ask someone, and I have had to do this in the past too with some of my students and some of my other peers. When you ask, you would just say, thank you for sharing with me. It sounds like you're going through a lot. I just want to ask for your safety. Are you feeling suicidal? Are you contemplating suicide? And sometimes it's easier too for some of us who have a harder time being more direct. You could ask, do you feel that you don't want to live anymore? When has this feeling for you began? Oftentimes it just starts with that validating the person, appreciating what they've just said to you, and then of course making a clear, direct conversation with them about it, and then coming up with next steps. How can I help you from here? Thank you for sharing that. That moves me that you trusted me enough to help you in this situation. What are ways that we can work together? And that's just an easier way to go into it. It is just a conversation. It's not rocket science. Anyone can have it.
Yeah, and I agree with that. I think this goes. I think that so. My mother told me this a long time ago when I was, back in my adolescent years, trying to figure out the world and trying to figure out my place in it. And I'm not sure what the original attribution is, but I think it's a Daniel Goleman. I think it's Goleman's work on emotional intelligence, and it's just my mother, parroting what he says. But she always told me that nobody cares how much you know until they know how much you care. And so I think that the more empathy that you can show to this, like when you ask the question of how are you doing, you have to really don't ask the question unless you really want to know the answer, right? Unless you're willing to engage all of the sometimes emotional baggage that we all carry with each other, unless you're really concerned about knowing the answer, don't necessarily ask the question. But if you're engaged with the person and you really are invested in the answer, then it's all about active listening. It's doing a lot of listening, a lot of just kind of making sure that they feel understood and cared about and connected with, rather than providing solutions. I mean, yes, we can provide solutions. Yes, we can provide you resources. Yes, there are active steps that we can take if necessary. But sometimes people are just really, really down. They're really they're in that kind of most down phase of major depressive disorder. They're not suicidal necessarily, but they are feeling very depressed, very disconnected, very isolated. And sometimes just that friendship or that element of human connectedness, I think sometimes doesn't necessarily pull them all the way out of that behavior or that feeling necessarily, but it provides maybe a little bit of light at the end of the tunnel, or a little bit of light in the darkness. And I think that's the biggest key that I've noticed.
Thank you both for that. And kind of thinking about our campus community, do you all have any recommendations, or what can we as ASU students, family members, work colleagues, and community members do to help others that are struggling with their mental health challenges?
Definitely. So this is an area that I have been working in, especially with graduate students, now that I identify as one. We're really trying to make those strides for students to be connected to the resources here. And not only that, the resources that do already exist within the community. Oftentimes when I was working in my undergrad, I was like, gosh, we have all of these resources, but they're so, they are accessible, but, oftentimes we don't know of them. So that's when I like to bring in this idea of education. What does this look like? So in the group that I was a part of in my undergrad, Devils for Devils, a group on campus that supports community as well as campus emotional health. They have a training talking about how you can have these difficult conversations in a constructive way that makes you feel safe and the other person feel safe. Another one that we also offer at ASU is safe talk trainings. They're a 4-hour training. It's essentially like mental health CPR. That's exactly how I would describe it. And so when we are in these situations where we are interacting with someone who is struggling, whether it is a student, whether it is a coworker, whether it is your peer, whether it's a family member, having those conversations can, of course, be difficult. But the thing that I really like to express is that you are not alone in having those conversations. I often think that when people, or at least what they've described to me is they're like, hey, I've been having a conversation with this individual. They've been really struggling. It seems like a lot for me to take on. Well, of course, there's a lot of emotion that is in that. And sometimes we're dealing with issues that are outside of our scope. I might be studying counseling, but I don't necessarily have the same skills as a psychiatrist. I can't get you medication. Or I might not have skills of a social worker. I can't get you those social environmental things to help you out, like food stamps, healthcare, all of those options. And so as advocates, as friends, as peers, getting educated in what is available to you is the most important thing that you can do. And even attending talks like this, because you get to learn so much more about what's out there by different people interacting with different things. And so as a peer, you can say, you know what, I got to go to this talk. I got to understand a little bit more. Even if you didn't get to go to the talk, you have resources on the back of your student ID card that you could use. And so when you have access to resources like that, you're more likely to use them. And not only that, you're more likely to help that other individual that is struggling. So I can always talk more about how we can improve and, expand our resources within the community here at ASU and beyond. Even like working in high schools, which is something that I've been doing for about 4 years, being able to go into those communities and set these younger generations up with the toolkit to be that beacon in their community. The education is the root of it. So if you wanted to make change today, talking and attending to these conversations about resources is the best. And honestly, I advocate the first way that you start today.
Yeah, and I love that idea. I love that idea of like mental CPR, right?
Mhm.
Like that mental health CPR is such a good motive. Now being trained as a medic, I also want to pair it with other tools, right? Like CPR is great if you're having a heart attack, right? And so mental CPR might be great if you are in an actual suicide crisis, right?
Mhm.
But if you're not, then there are other tools that we can also have in our back pocket, which are super easy to carry. And one of those examples in the medicine world and emergency medicine world, particularly, is the idea of naloxone, which is the opioid reversal agent, right? And it's usually a nasal spray. Again, a lot of people carry them. A lot of first responders now. There's a lot of police departments that are actually making their officers carry them because there's such a huge harm reduction correlate there in terms of reversing opioid overdose. And so I kind of see like the mental health equivalent of that to what we're talking about here, in the sense of, by asking somebody how they're doing, by caring about them enough to ask them the question and really want to know the answer, the thing that I think really changes the game is the continued follow-up. It's the not leaving, letting them know that they're not alone, that you're never alone. You're not going to feel this way forever. And more importantly, you're not going to go through any more of this by yourself and feeling isolated, because I'm here, because I want to be a part of your recovery. And I want to be here with you the entire step of the way. I think that follow-up is an increasingly important thing that we're starting to notice be even a bigger part of harm reduction in this area, but then also how we're just helping make society a little bit better, a little bit more tolerable, to live in. Because otherwise, life is hard, it's lonely, it's, life is a lot of things, but being connected with people makes it sometimes seem lighter, and seems better than it sometimes appears at first glance.
Yeah, thank you both for kind of sharing some of those resources and tools. And, something that I thought about as you both were sharing, it came back. I started thinking about kind of some of those warning signs before we even get to like disseminating and sharing these resources, right? What are some things that, as friends, as colleagues, as students ourselves, we should be watching, we should be attending to when it comes to our peers or even ourselves, maybe some of those risk factors or warning signs that someone may be struggling with their mental health?
Definitely, I can take this one. So, one of the things when I give presentations on mental health, having those conversations is this first step, which is being aware. How do we know that someone is experiencing some sort of mental distress? Typically, I like to separate these out into two categories. So, the first category, you have academics, because we are graduate students, and we have career. So oftentimes you'll see that someone might be not coming to class or showing up late to work. Other times you can see a change in their behavior where you notice, maybe they don't eat lunch in their lunch hour anymore, or perhaps that they're going out and they're getting foods that they usually don't, and any sort of change like that. So oftentimes what we're seeing when we see the academic career, because that's when we're surrounded most by our peers, is that they're withdrawing. Something doesn't seem right. Then you have this other category, which is this interpersonal. So you're seeing changes in emotionality. Are they more irritated? Does this person that is usually very calm and collective suddenly have road rage in the kitchen? And those can be like kind of like extreme ideas, but even just noticing that someone's just a little off, something, they're very slow, those things can come through. And then another area that when I give presentations like this is being able to tell the difference between warning signs and risks. So when we look at warning signs, like I just said, there's things that we can see, there's things that we can feel. The difference between it being a warning sign and risk is just severity. And honestly, I feel that this is very subjective. If you look at the situation, you're like, okay, does this person have suicidal thoughts, or are they contemplating suicide? Are they planning it out? Do they have some sort of plan in mind? Those are two different, there's a sign of warning and it's a very severe warning. And then there is severe sign of risk. That's of course, when we connect people to resources, but even to higher services of help. So that would be calling a hotline, or even just seeing if there's anyone at the counseling services center that could see that person that day. That is a time when we look at those warning signs and the risk signs and we escalate it. We refer those individuals to help. And I think that's, there's many signs that you can look for, but, those are just the ones that I really like to push out into the community because it's easy to see, and we're all connected in that way.
Yeah, and I agree. And I think that the most important thing, to consider is that balance and that trade-off between risks and risk severity versus actual warning signs of imminent behavior, right? And sometimes that line, it's so hard to sometimes even draw that line or draw that balance because like even observing the warning signs, it might work in maybe 50% to 2/3 of the cases.
Mhm.
But there's strong background in this, in the research on this, and the literature on this, is that anywhere between 1/3 and 50%, so 1/3 and half of people that are suicidal and go on to actually commit suicide and die by suicide, they don't exhibit any symptoms beforehand and they show no warning sign whatsoever. And they seek no help or treatment for it either. And that's a huge percentage. I mean, if that's 1 in 3 to 1 in 2 that never show those symptoms or never show those signs, that's a big deal. That's a hard thing to get our mind around, and that's what makes drawing that line very difficult. Now, there are typical warning signs, you know, I mean, engaging in self-harm where, you know, they have no history of self-harm, acquiring access to means of potentially attempting suicide. So either stockpiling certain medications or, you know, outside their normal purchase history. I mean, if you never go, you know, if you never buy Tylenol and you never take Tylenol, but then all of a sudden you go and, you know, get a giant bottle of it, that's a change in behavior, right? But stockpiling medications is not a good one, a warning sign. Also, giving away prized possessions is a typical red flag, big warning sign. You know, mainly because people don't part with possessions, let alone, you know, prized possessions. And so there's those type of things that you can look for. But then there really becomes it becomes this, you know, not about the warning signs, it's about the risk factors. The risk factor category kind of breaks into 2 parts, right? There's the biological or there's the biophysiological risk factors. And then there's the social psych components, the environmental triggers that Emily was talking about earlier as well. And I think those are 2 different things. We can talk about them if you want here as well. But I think that those are different triggers and different things to look at. And like you said, the question becomes is about the severity, the risk severity. Like how much is this, you know, are these factors causing this person to struggle?
Yeah. Well, thank you both for that. And I think you all kind of brought up an important, I guess, distinction here between warning signs and risk factors, and how risk factors are the things that we're kind of more concerned about. And you all both kind of alluded to these 2 different categories. Maybe you all could elaborate a little further in terms of what might be in each category. I think you mentioned like the biophysical and something the psychosocial. So maybe you can share more about that.
Emily, you want to go first or you want me to go first?
I'll let you jump in first.
Okay. So in terms of the biophysiological stuff, or the genetic risk factors, there are considered 4 kind of big ones that are worth looking out for, or particularly if you're a clinician and you notice this from the person's, you know, electronic medical record or whatnot. Any pre-existing or previous history with genetic risk for depression. So those are genetic diseases or genetic predispositions for those diseases, either bipolar disorder, schizophrenia, major depressive disorder, you know, those type of things. Diagnoses of substance use disorders. So any substance use disorder, most common, you know, are opioids and alcohol. Mainly because alcohol is very easy to obtain, and so it's a very high access item. Opioids are kind of just the other 800-pound, you know, elephant in the room that we don't like to sometimes talk about, or that we sometimes, you know, see a lot on news reports. Other involvement with violent behaviors. So again, anything that indicates self-harm. So whether that's, you know, cutting, burning, blah, 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 like any of the typical self-harm behaviors, those are also kind of indicative as a, you know, physiological component. And then obviously previous suicide attempts, because that's the largest predictor of people who then go on to die by suicide. Is, did they attempt before, or was this a first attempt? And usually it's not a first attempt. It's usually the repeat attempts that go to die by suicide. It's not first attempts. First attempts aren't always very successful. And then to go back to the, you know, social and environmental or psychological triggers, recent terminal illness diagnoses. You know, so I think cancer, a recent cancer diagnosis is not always an easy thing to deal with. That's a sociological trigger. A sudden or expected loss of a close relative, which we kind of saw a lot during COVID, because of the loss of so many people, or significant other or spouse, a significant partner. Those are all ones. Loss of employment, like a big financial loss or legal trouble, like legal consequences, is the third one. And then the fourth one is displacement or loss of housing. And so a lot of people sometimes get affected by these different sociological and environmental triggers and get pushed over that tipping point, past the breaking point. And that's what really kind of triggers that thing. But Emily?
Yes, I think you summed that up so wonderfully. Going back to just your talk on substance use and other risky behaviors that we see, I feel like from my stance as being a student and also a student that has been connected with other students and peers that have struggled, substance use and behavior change, that was a huge red flag for me. So oftentimes I would meet up with a student, just trigger warning. I did meet up with a student who was in the middle of an overdose and was able to help them get help. Some of the things that they were before were they were super involved in so many community things, but then slowly dwindled away and eventually dropped out. I think, talking about very sudden life changes for students, sometimes it's coming to school and also being maybe in a new state. You moved your whole family. There's different struggles that graduate students face as we are a different and older generation of students coming to learn. And so when we have those struggles, oftentimes substance abuse can come in, or excuse me, substance use. And so when we see engaging in different behaviors, so having the withdrawal, but also these risky behaviors and stockpiling medication is something that I've also seen from students. Those can be great ways to see red flags. And I feel like it's often not talked about. Typically, when I talk about the signs and warnings, it's very superficial. But there are deeper events and unexpected life events that happen. And that can be an opportunity for us to step in and say, hey, I saw that you were sick this day, how are you doing? Or I heard that, there was some stuff going on in your family. I just wanted to check in on you. That's another time for you to just intervene and see, where this person is according to warnings and risk. And so again, Erin, I think you summed that up just beautifully. So thank you.
Well, and I want to go back because you brought up a really good point. So that's kind of social isolation, or that lack of connectedness that students, that even domestic U.S. students that are from a different state, and they lose kind of access to their social network here in Arizona, or they have to rapidly form a new social network, which, whether it's, generationally speaking, making friends is always hard. But particularly hard in a digital era, where those friendships are sometimes even mediated by technology. I think that's one of those interesting generational phenomenons that we're going to have to continue to do research on, and that's where my research gets the most interesting. But I want to also go back to the point of to drive this home for kind of the international students that might be listening. 40% of graduate and professional students are attending institutions not in their home country. So that's a big percentage. I mean, if you have 40% of people that are not attending in their home country, their home language, they're in a new place that is maybe potentially far away from home. I can't imagine, because I've never been in that position, but I can only imagine how much more jarring it is for those students than just the out-of-state students, right? Like, I don't want to mitigate anybody's experience, but I can only imagine that the social isolation and the social lack of connectedness becomes that much more exacerbated. And I know that GPSA does a lot of work here to connect students together, international, domestic, all stripes, all creeds, everybody across the spectrum. We are trying to build those connections, and it's because those connections are so important, those networks are so important, that we want them to be very close.
Yeah. Well, thank you both for that. And thanks, Erin, for those statistics. That was insightful information. So going back to something that I think you both alluded to, It pertains to depression and other mental health disorders, as well as substance use disorders. Are individuals with these particular disorders, are they at an increased risk for suicide-related behaviors or even suicidal ideation?
Erin, I believe this is more so in your wheelhouse.
Sure, sure. So I can absolutely answer this question a little bit. So in terms of the risk factors, like there are predispositions. So I mean,
Mhm.
substance use disorders, any of the substance use disorders are particularly not good. Um, they have risks associated with suicidal intent and behavior. Um, but obviously there are ones that are more strongly linked or more strongly associated, and
Mm.
any of those that fall in that kind of general depressant or mood um disordering type of medications. So think alcohol, opioids, benzodiazepines, anything that kind of acts as a typical central nervous system depressant is important to consider. Um, and I think those are just those are just kind of those type of risk factors. I think the other interesting risk factor that sometimes you know, doesn't always get played up is the sex and gender differences between intent and behaviors. Um, and one of the interesting things to highlight, again, just talking statistically, suicide deaths, the death rate is 4 times higher for males than it is for females. And the death rate is mainly based on chosen method of attempt, right? And that's why it's so much higher in the males. But then one of the things that sometimes gets pushed to the back burner is the attempts. Uh, Attempts are actually 3 times more likely in females than males, and so there's a distinct risk um, that we're talking about in terms of just those basic sex and gender differences and those different characteristics that are worth looking at. Just from an attempt versus a death standpoint. Age and race, those are always interesting characteristics as well. So speaking age wise, suicide risk increases with age. So anywhere between 10 and middle age. It increases as you get older. The most successful or the most susceptible age is actually middle age. So middle-aged folks are more at risk than anybody else. But the second highest category is actually that 18 to 25 category, which unfortunately is a lot of students, both either graduate students or undergraduate students. They're the second highest risk category, based on recent data. And it's important to know that when you're looking at age demographics between the ages of 10 and 39, suicide is the second leading cause of death among that age group. And that is a startling statistic. Like the number one cause of death is usually unintentional injury, which usually is automobile accidents. So motor vehicle accidents is the number one cause because of car crashes. But number two is suicide. I mean, and that's a startling statistic to think about. But whites, speaking from like a racial standpoint, whites are two to 3 times more likely compared to the other races to attempt suicide behaviors. Native American and Alaskan natives are the second highest rate. So again, they're particularly vulnerable. Immigrant rates are higher than native or domestic persons. And so like that's just some of those interesting, kind of things to consider more. And obviously, I mean, they're risk categories that we want to continue to address. The other thing that's sometimes always interesting to look at is marital status or relationship status, because it's the one thing that we all change on social media. It seems to be the one change that's always highlighted. So marital status is important as well, because marriage and children lessens the risk factors. It dramatically decreases the risk. So much so that single individuals are 2 times more likely compared to marriage people to attempt suicide behaviors. Divorce, again, that's one of those emotional social triggers that triggers. And so particularly more among divorced men, they're 3 times more likely than females to attempt suicide. And then, like I said, I mean, the family history with, with social isolation increases risk, family history of suicide, family history of depression,
Mhm.
and then one of the other areas that I don't know a ton about is that the difference between homosexual individuals or people identifying as that they're more at risk than heterosexual individuals, and then the recent transgender, non-binary. Those statistics are super muddied. They're super unclear. There's not enough research going on here, and so I know that sometimes there's different statistics being thrown around. The 4 in 10 or the 41% number that you sometimes hear about transgender individuals. Those numbers are not very good, and and it's not because the scientists did anything wrong necessarily. It's just that the science is so nascent on this, it's so new that there's not been enough research done on that population and on that group of individuals that are
Thank
worth considering. So
Thank you for providing some of those statistics and kind of thinking about, we've talked about risk factors. Now I'm thinking about protective factors. What are some of those factors that might mitigate or reduce one's, likelihood of engaging in suicide risk behaviors or having suicidal ideation?
Definitely something that I've noted in my schoolwork, and then also research that I've done alone. They have this idea of resilience. So this is being able to combat difficult situations that you might experience in your life. And this book that I had read, which is The Body Keeps Score, it was a New York bestseller, so some of you might be very familiar with it. They talk about for children that experience trauma, that having that one consistent person was very important to building resilience, being able to come back from something that was very traumatic or very difficult for that individual to handle. And I feel that the same concept applies to this. So being able to have a community that you can rely on, being able to have a support network, being able to learn what that looks like and build it for yourself and be a part of others. And that's just something that, as a student, I look at, and also as someone who advocates for resources in the community that I look for. I look for the individuals who are not connected, who might be new, who needs a direction and a place to connect to. ASU, just in general, is a huge, huge, huge campus. There are so many people around us. And with that, we have tons of people who are just looking for those connections. It's a very open campus in that way. And so when I look and, I refer students who are struggling, the first thing I say is like, well, what connections do you have on campus? Who are your friends? Who are the clubs that you go to? What do those look like? Do you go to the rec center? Are there groups of physical activity that you participate in? Even for students who have disabilities, being able to find a community where they feel understood with their stance. So protective factors in that sense, definitely just having those connections and being an example for others in the community, saying, referring them. It doesn't have to be a professional referral to counseling or other medical needs. It could be community needs, inviting someone to your yoga class or Zumba, inviting someone to go on hikes with you. Being the friend in the community is a great way that you as an individual can be that protective factor. And that's something that I really like to look at when I think about suicide, is that we ourselves are our own tool. We are our own beacon of hope. And within the work that I've done on campus, it's definitely, you feeling that you can empower others and you can empower yourself in a safe manner. And so that being said, connection is key, which is some of the basis of what we really try to promote here on campus.
Well, I think to build off that, and I love that, but to even build off that social connected piece more, like it's sometimes interesting when you look at some of the substance use research, and you look at the 12-step program specifically. the final steps in the 12-step program, the reason that it's so successful at harm reduction and at substance use disorders stuff is because the final elements involve helping somebody else and providing service to somebody else. And that's where that sponsorship idea really shows up from. And so I think that, yes, increasing that social connectedness is amazing, and helping others and being essentially a sponsor to somebody else who's suffering is awesome. But then I think it goes back to those other kind of social elements. Like, I mean, if you look at the risk factors, if loss of housing or loss of employment are risk factors, then the opposite are also true. So, finding connections to people is important. Finding connections to other things that are meaningful, like employment, education, housing, all of those things are important as well. And so whether it's taking on roommates, or whether it's finding roommates and connecting people that are trying to connect with others, or whether it's finding somebody else a job, or whether there are lots of other ways to serve other people, right? And help this issue. I mean, I think it's a hugely important issue, though, in terms of productive factors that we look at everything and try and really figure out some of this stuff. Some of the other biological things, I mean, working out is excellent. Physical activity is amazing. So sometimes even just pulling somebody out of their space, and getting them to go outside. Vitamin D exposure is kind of magical. It's not always well studied either, but in this case, at least, like some sunlight exposure, or any of the memes that you see flying around, like touching grass, kicking rocks, like just go outside and hang out in the sunlight. Sometimes that's just enough to get you back on there's more to life than what I'm thinking, and get you out of that kind of negative thinking or that rumination on how bad things are. Just sometimes interrupting or breaking that cycle of rumination is critical, and an easy way to do that is physical activity.
Yeah, well, thank you both for sharing those kind of like protective factors. And I love that piece about connection, and how my hope is that, our students on campus are connected in some way, shape, or form. And for graduate students to get connected with GPSA and the things that we're doing here. So on a final note, I just wanted you all maybe to give one final takeaway, or something that you want everyone that is listening to know about graduate student mental health and suicide prevention overall.
Absolutely. I think if there's one thing to take away here today, is that you can be the individual that can connect with the other person who is struggling. You can be that change, and you don't have to do it alone. There are so many resources on campus that, I could talk for an hour about, but you can walk to counseling services and get a same-day appointment. Even though they talk about long wait times, those typically are shorter. They will refer you out to other options in the community, and they always have spaces built out in every counselor's day to make sure that if you are in immediate crisis, you will see attention that day. That being said, there are other ways that you can connect to resources. If you're sitting down with someone and you just don't know what to do at this point, it's okay to say, I'm here for you. What's the best way for me to support you? And I'm not sure where to go from here. Can we call a hotline together? Can we call the impact hotline together and just talk about what they might recommend for you? Being able to connect to resources, even if it's something so like broad as the dean of students on campus, being able to make those changes, and really know that you are, a person that has so many connections. You might just feel like one person, but you truly have a whole team behind you. There are so many resources in the community that, again, I could talk for an hour about, but you can be that change. And it is because you are not alone. You are connected to so many students, and that is something to be extremely proud of as a Sun Devil. So just even being here today and knowing that GPSA is, right behind you, making sure that you have these resources, you have different outlets on campus sharing out these wonderful opportunities to connect. you are not alone and you are that connection. So really just empowering yourself to be the change in someone's day and knowing that it's okay to ask. And that's really what I would truly leave you with.
Yeah, that's amazing. And I just want to build off what Emily said in the sense that, you know, one of the things that we kind of highlighted here in the topic of, you know, the flyer was the concept of staying around because your life matters. You know, sometimes it's hard to see your purpose. Sometimes it's hard to, you know, struggle, and sometimes we get caught up in our own stuff, and we begin to think that our life doesn't matter. But I promise you, it does. And yes, we can connect with each other. You know, yes, you can reach out and talk to people, and I think that human connection is so vitally important. That would be my recommendation to people from the takeaway from this webinar is you can reach out and you can be that thing. You can be that person for somebody else. And if it's just getting them to stay one more minute, one more hour, getting them to stay and understand that you do care about them, that their life does have value, that they're not less than, that they're more than. All of those things are hugely important. And that's the one thing I would leave you with. But obviously, I mean, there's tons of resources here at ASU. There's the new 988 number domestically in the United States. So the suicide hotline number is now just 3 digits. It's 988. You can call, text anytime. It's always staffed 24/7, even including holidays. It's always staffed by people that are willing to talk to you and willing to help you, you know, work through issues. It's an amazing resource. It's like I said, it's brand new. I mean, we've had 911 for a long time. 988, call, text anytime. But then obviously, I mean, we have lots of ASU resources as well. But just remember that you're not alone, that there are people here. There are lots of people that care about you and want to see you be successful.
Well, thank you both. Thank you both for your time today and for sharing your wisdom with us and engaging in this conversation about suicide prevention and ultimately thinking about graduate student mental health and well-being. So I think that was a great way to conclude today's webinar. So once again, thank you. And I hope those that are listening are able to take something away from today's webinar. So thank you.
Thank you for having us.
Thank you very much. I appreciate it.